to Radio CAHS, presented by CAHS Chief Executive Dr Aresh Anwar.
Welcome to Radio CAHS.
Welcome to Radio CAHS. I can't start without acknowledging the support we get from Radio Lollipop and DJ Houston. Thank you very much for coming in again today to help support us. I'd like to actually start by acknowledging the traditional custodians of the land, the Noongar Whadjuk people and the Aboriginal people of the many traditional lands and language groups of Western Australia, and pay my respects to elders past, present and emerging. I think it's important this week to acknowledge the announcement that have been made to try and ensure that we really address the gaps in outcomes that we witness and are so much responsible for making sure we close. So I'll just remind everyone that you can call on 6456 5629 or text to ask a question a little later in the show. And once again, we're very fortunate to have Dr Dan Yeoh join us for a COVID update. And our feature today actually involves inviting Sue Kiely, who's the Acting Director of Strategy and Planning. I don't know how actually she's managed to find time to come, because I don't think I know anyone who's running as many programs across the health service as she is. So, and she's not pulled all her hair out yet. So we normally use this first part of the show just to provide some update. I just wanted to acknowledge that when I last talked, we'd announced some pretty big changes to the executive structure, and that's undergone a period of consultation. And I really want to thank the exec and the co-directors and the feedback from other colleagues that have helped finalise the structure and the plan that was put forward, and an announcement should be going out very shortly regarding that. I also want to reflect on really the very challenging national situation that exists around COVID, around Victoria, and remind us, and I think it's actually, I don't feel that is the case, but remind us that there's no room for complacency. And we really need to focus hard on preventative measures. So one of the things I know, and it's a terrible thing to highlight, but we are so fortunate in having staff being so dedicated to work, and for so many years we have tolerated when people have come in when they've not felt 100% because they've not wanted to let children, families and colleagues down. I think we're in a place where actually we just have to say, if you're unwell, please stay at home. You do not need to feel guilty. The real challenge would be for us to explain if we got spread within the organisation. So your colleagues, I think, would want you to protect them, and we really would value staying at home. I know that in some hospitals that staff, before they start work, gather round and make an attestation statement around that they're all well and provide each other with assurance. And I was fortunate enough to talk to leaders from other children's hospitals around Australia yesterday, and in places where there are outbreaks, staff are actually filling wellness forms prior to coming in to work. So what are some of the lessons that we can infer from Victoria? Well, 90% of recent new COVID cases didn't isolate immediately after feeling unwell, and this is felt to be a fact in driving community spread. 50% of new COVID cases did not isolate after being swabbed. They went to work, they went to shops, and they went to see friends. The majority of people recently diagnosed, I think, fall between the ages of 10 and 49. And so I suppose one of the maybe myths now, maybe we could touch on this with Dan, is that this is a disease of the elderly, and that certainly does not seem to be bearing fruit as we see more and more cases. And what I think I was most surprised about was that hospitalizations appear to fall into two brackets: those over the age of 60 years and actually in individuals around 20 and below. And Dan, you may want to challenge that. So I suppose as a children's hospital, we have really focused on, one, being prepared for the children, but also really being acutely aware that our staff base is also vulnerable, and protection is key to that. Dan, I know that you've been kind enough to provide us with a regular COVID update, so maybe we could touch on some of those facts. I also just want to reflect a tiny bit on surveys and staff feedback. So the Minister for Health survey recently had some, the information was pulled together, and we've started to disseminate the action plan that comes out of that. I suppose I know that as a member of staff, it's nothing more galling than to have provided feedback and to see no action, and then to get another survey asking you the same type of questions again. My first statement is that we are genuinely focusing really hard on making sure that you said we did becomes an absolute reality across the organisation. And I know Valerie Jovanovic, who actually came to talk about her role as ED of People Culture and Capability, is really dedicating a lot of her time and focus to making sure that staff well-being is something we absolutely deliver on. So can I please ask you for some faith that when you are providing feedback, that what you will see is a transformation in the organisation as a consequence of your experiences and the time you take to help inform us as to how we can be a better place to work. So with that, I think we may be able to go across and try and I'm getting the stadium always has.
Call now on 6456 5629 or 0436 595 600 to ask a question.
Now, during that little bit of song I was told off, because apparently that technical piece is called a sting, and I should technically, if I was a professional, not introduce a sting. So I will try and refine my radio skills. Now, for a highly skilled individual, Dr. Dan, welcome.
Well, thanks, Aresh. Happy to be here.
Brilliant. Dan, was there a particular area of focus that you were going to pick on today?
I thought talk a little bit about vaccines. There's been a little bit that's come out recently, I think, and also happy to talk a little bit about what's going on in Victoria, which is, as you sort of inferred, is quite sobering. What's happening there.
So could you? Yes, because it's interesting. Because I think there's sort of one day you wake up and you're. One seems to be super hopeful about vaccines, and we read about the Oxford trial, and then the next day we get maybe a more sobering thought as to the reality of that translating into a product in the near future. So it would be great to have some formal feedback about it.
Yeah, certainly. So I think, as you say, sort of, I think we're understanding more and more each day, and it can be a little bit of this flip-flop that sort of, I think initially we found that a lot of people developed antibodies after infection, but then there's been some papers saying that antibody levels come down very quickly, so the immunity that you get might not last. It's been a bit similar with the vaccines, but actually over the last 2 weeks and over the last week, we've seen some really positive results. I guess as a bit of a background in terms of understanding the vaccine trials, what we know about the coronavirus is that it has a spike protein, so that's a little spike that it uses to infect the cells in the lungs and the nasal sort of cells of the patients who become infected. And what we know is that this spike protein also is shared by the old SARS as well as MERS, which is another coronavirus which initiated in the Middle East a number of years ago. And we know that if you get antibodies or an immune response against this spike protein, it actually can help protect from infection. So I think very early on we knew that that would be a good target to try and sort of, I guess, develop vaccines. So that's where things have really, I guess, started from. And we know that in terms of immune protection, you might have heard a lot about antibody response and neutralizing antibodies. So antibodies are, I guess, proteins produced by the B cells in the body, which are able to sort of bind to, I guess, pathogens or infecting viruses. And we know that sort of people who have recovered from COVID will have antibodies against this spike protein. And so I guess when we're trying to develop vaccines that protect, trying to induce production of these antibodies against the spike protein is important. And then there's another sort of area, broadly speaking, which are the T cells, not the B cells. And the T cells are really the cells that orchestrate the immune response to viruses. So we really want to know that we can get antibodies against the spike protein and also T cells that recognize the spike protein. And there's been a number of vaccines over the last couple of weeks that have I guess have publications to show that they can induce both an antibody response and a T cell response, which is really promising as an early sort of finding. So yeah.
And Dan, can I ask, is that the same vaccine or different vaccines triggering different things?
So yeah, it's a really good question, Aresh. I think there's now I think over 130 vaccines at various stages of development. So really there's been a worldwide acceleration of trying to develop a vaccine, and there's, I guess, a number of lead candidates. And I think in terms of the really interesting stuff from infectious diseases immunology point of view is that a lot of the vaccines that we have in our normal schedule are based on two basic technologies. One is sort of using the virus itself, or a killed virus. So I guess thinking about the virus itself, a weakened virus is what we use for the measles vaccine, or a killed sort of organism is what we used in the old whooping cough vaccine. And essentially you sort of get that, put it into the body, and then sort of the body develops immune response. And then the other major type of vaccine that we use is really the protein or subunit vaccine, where we take a part of the virus that's not viable and then inject it sort of into the person, and then the immune system recognizes it and develops an immune response. And there are a couple of, I guess, COVID vaccines which use either, the whole virus itself killed or a subunit vaccine, including some that are in trial in Australia. But actually, a couple of the leading candidates are using relatively novel sort of technologies. And again, coming back to what we said about coronavirus having this spike protein, what we really want is that for the immune system to, I guess, encounter the spike protein and then develop immune response to it. And there's two newish ways that they're doing that. One is to just, I guess, inject the genetic material that encodes the spike protein, and then making the human body cells make the spike protein itself. And that's sort of the mRNA sort of vaccine, which is made by Moderna in the States. And then another way is using sort of a vehicle. So using most commonly an adenovirus, which is, I guess, a weakened virus that can cause sort of, it doesn't cause disease in humans, and inject the genetic material for the spike protein into that, and then use that as a vehicle to introduce it into the body, and the body itself makes the protein sort of using the cells in the body. So really sort of quite neat ways of getting the body to encounter this spike protein and produce a response to it. And the Oxford vaccine that you talked about uses a chimpanzee adenovirus to do that. So yeah.
And I suppose, Dan, do you have positive clinical trials in July 2020? Any idea as to what that really translates into, say, for us in Western Australia, as to something we may pitch up at a clinic and have a jab with?
So I guess, as you say, I think there's some promising early phase 1 and phase 2 trials from Moderna using the RNA vaccine, as well as Oxford using the adenovirus vaccine, and then also other groups have used adenovirus vaccine. But what these really have looked at is safety in the first instance, to make sure there's no severe side effects, and sort of those ones which have been published in early phase 1 and 2 trials have shown safety. And the other thing is looking at the immune response as you measure it in the lab. And both with the RNA and the Oxford adenovirus and the Chinese adenovirus vaccine, they produced both the antibody response, which is really good, as well as a T-cell response. So all of that's quite promising. But in terms of trying to get to the next stage, the next step really is to try and, I guess, demonstrate that having these antibody responses actually protects you from being infected. And there's, I guess, a couple of steps to that, and you could test it in animals, and that's happened for the RNA vaccine, and it actually looks like it reduces infection in the lungs and the nose. And the Oxford vaccine's also done the same thing, where it reduced infection in the lungs in chimpanzees, but less so in the nose. And eventually then you go on to sort of what they call phase 3 trials, where they sort of, immunise a large number of people, up to 30,000, and really sort of see whether the vaccine in real life can protect you. And so the RNA vaccine made by Moderna in the States has just started their phase 3 trial, and I guess they started recruiting patients sort of as of this week, I believe. And the Oxford vaccine is also very sort of advanced in that, and I believe the phase 3 trial is either starting or soon going to start. And there's a couple of other adenovirus vaccines, one by Janssen and one by the Chinese company, that have sort of are hoping to start phase 3 trials, and also another Chinese company who's using a killed virus sort of vaccine to start human trials. So actually that phase 3 trial is sort of where you really are able to demonstrate that this vaccine works to protect you from getting infection. But so far, the results from, I guess, these phase 1 trials as well as the animal trials suggest that there's going to be maybe a number of candidates which might be protective. But until we get the results of these phase 3 trials, we really won't know what anything, whether these actually work in real life or not.
That's absolutely fantastic. I think, Dan, if you ever want to moonlight, you have got a very, you've got several careers you could pursue. One is as a radio artiste. The second one is as a teacher, because that's... I, having been in medicine so long, I don't think I've had such a clear explanation of vaccines and immune reactions and protection before. So that's absolutely fantastic. Can I just ask you, I do want to go back to a piece I did when, just in the start to the programme, when I talked around the ages of presentation. And I know you raised an eyebrow, which you can't see in a radio show, so I will describe it. I just wondered whether the data around children, because we'd had a conversation in this show about Kawasaki-like presentations, and I just wondered whether the data was changing our view of how it affected children or not.
So I think, yeah, absolutely, we're learning more and more. I think what we've seen in Victoria locally is that compared with the first wave, where a lot of the cases were in return travellers and older families, and cruise ships, actually in this second wave, a larger proportion of the cases have been in children. And my understanding is that they've not had a huge number of, I guess, admissions or very unwell children, although I guess as a proportion there may be more children involved this time around. Yeah. And as I understand it, sort of they may have seen a small number or maybe 1 or 2 cases of PIMS TS in Melbourne, but not confirmed. But so far, I think those cases have done well. But certainly we know that even in sort of one of the clusters in one of the high schools, that transmission between particularly older children does occur, and that's been reflected in some contact tracing studies from overseas. Probably a smaller proportion overall in terms of overall cases, but we know that actually when you get large community transmission that all ages are affected, and even though the proportion of patients who end up sick if you're under 50 might be smaller, if you get enough people infected, you're going to end up with people in hospital and in ICU. I think the highest risk in terms of getting into ICU is still probably in the older patients, but really what we're learning is it doesn't discriminate, and if there's enough of this transmitting, there's going to be people in each of those age groups that runs into trouble.
Well, that's fantastic. I suppose I'll just go to some of the questions that we've been given. Beck, could we just turn to you?
Of course. One question that's been hot in the press this week is keeping the borders closed a viable option to control the spread, or are we just delaying the inevitable?
Yeah, so I think sort of that probably refers to maybe some of the court action that's happening with Clive Palmer trying to enter into WA and us having sort of very hard borders. I guess some people might have advocated for, I guess, a gradual border opening. So say opening to states like South Australia, the Northern Territory, Queensland up to a week ago where there wasn't much community transmission. I think at this stage the position of the WA government is that they would prefer to keep a hard border. And I've spoken to a number of people about this, and I think the preference I sense in the community is to sort of leave us alone in WA. I think what we have seen with the Victorian outbreak spreading into New South Wales and then leading to several clusters there, and then just as of this last week going up to Queensland, is that although places like New South Wales may not have had transmission, the people who came from Melbourne via Sydney to Queensland brought in a few cases there, and it sort of really sets you back in terms of, I guess, what you're able to do and having to sort of contact trace. And as what we've seen in Melbourne is that once things get out of control, it can be very difficult to try and contain things. And already in Melbourne, the proportion of people in hospital and the occupancy of ICU beds is continuing to climb, which is quite worrying. So I think although some people argue for relaxing, and I've seen sort of, I guess, several pieces in the media of people calling for relaxation of measures, relaxation of border closures, I think sort of it is quite dangerous, and as I said earlier, we can't really be complacent, and it would be nice to be able to, I guess, contain what we have, and we've been very lucky so far, and to undo any of that, I think, would be dangerous.
It's interesting you say that. I was just looking at the headlines at the West Australian today where there's a huge number, 96% back hard border, and a petition of 200,000 people supporting that as well. So you're right, the strength of community feeling is pretty high, and the sense of anxiety is pretty high.
Yeah. Yeah, absolutely. And I think the other point to that is that there's a bit of a sentiment sometimes of why don't we just let this go? And I think that speaks more towards sort of the herd immunity argument that we're all going to get this anyway. But what we've already seen, I guess, over the last 3-4 months and probably the last couple of months is that now we know a lot more about effective treatments. We've seen the recovery trial showing dexamethasone reduces deaths. We've got access to remdesivir, which may reduce mortality, but definitely helps people get better quicker. I guess we've upscaled our access to ventilators and sort of ICU beds. And I think also the vaccines, sort of all the data is quite promising so far. And even if we have a vaccine that's able to reduce severity of illness and not totally eliminate transmission, I think it'd be better to sort of, I guess, face spread of COVID with that in our pockets rather than having less tools. So I think the more time we can buy, the better space we'll be in to sort of, I guess, be able to combat if there is ongoing community transmission, or if there's a vaccine that's totally effective in stopping transmission, obviously we won't have to face that. So I think time is key here, yeah.
So, Dan, can I again just reiterate that, because we continue as an organisation to meet and discuss regularly this issue of COVID preparedness, because it isn't a final state that you arrive at. It is one is that we just have to make sure staff continue to remain trained up and vigilant, and that we as an organisation constantly are reflecting and learning from the outside world around interventions and processes that minimise risk to staff and enhance the chances of children getting better quicker. So I just wanted to, I suppose, in part provide assurance that we as an organisation remain very committed to COVID preparedness, but also, again, ask staff to constantly reflect on the skills that they need to maintain in order to be ready should we have to deal with an outbreak of COVID.
Yeah, absolutely. And I think it's really important to keep on thinking about this, because as what we've seen is the evidence is changing, and sort of to learn from the experience of other states, I think, is really important.
Thanks, Dan. Beck.
One more question, a bit of a strange one. A cyclist with COVID-19 leaves Venice at 2:35 p.m. and travels at 10 kilometres an hour. A second cyclist leaves along the same route at 2:45, travelling at 16 kilometres an hour. How far do they travel until the first cyclist is at risk of infecting the second one?
Depends if they're both taking the same road. I guess preferentially you'd want them to be taking separate routes, and I guess ideally, I'm not sure if they're wearing masks in that, but if they were to be taking the same road. But
how far down? How far?
So the teacher's coming through in Beck.
I'd probably have to sort of sit down with a pen and paper and a calculator, probably. 2 hours, is it? Yeah, no, 2 minutes. I'm trying to get
kilometres.
Some hits here. 2 kilometres. 2 kilometres. Yeah.
Beck, that was the first opportunity we had to offer a prize on this. So maybe what we will do is put out a prize, because I think that's a pretty standard maths question for year 10 that's been made ready for the modern COVID time. So the next time we meet a competition.
Text in your answers and we'll announce the winner in the next Radio CAHS in a fortnight.
Okay, fantastic. Dan, thank you. That's, as always, fabulous.
My pleasure, Aresh.
Welcome to Radio CAHS, presented by CAHS Chief Executive Dr Aresh Anwar.
Welcome to Radio CAHS.
Look, it's fantastic. It's a great pleasure for me to introduce Sue Kiely, who's currently the Acting Director of Strategic Planning, but actually is normally a co-director in Community Health. Sue, welcome.
Thank you.
Now, Sue, have I interrupted you immediately?
No, I said great to be here.
Oh, fab. Now, Sue, just before we launch into questioning you, I wondered whether you could just give us a bit about your background and how you ended up in the post of Strategy and Planning.
Oh, goodness. Well, I've been in community health for around 20 years. Came across, my background is social work, so I actually was working in child protection previous to coming across to health, but was working in child protection in parenting and started to work with colleagues in health in designing some home visiting programs. And so then moved across to community health and have spent 20 years in various roles, absolutely passionate about the preventative health care that's delivered in community health, because it's such an amazing opportunity to be out there working with families at really early points in their lives without crisis of health. An amazing team out there in community health, and a great opportunity to learn about the health system. I've been across into a couple of different roles here in the hospital, and that's been really eye-opening as well. I've got so much respect for colleagues in here. But I guess in the community health setting, we do tend to work with partners quite a lot. We get to hear about what's happening, and so I started to do a bit of kind of project work and working across government with different agencies. So I think that sort of helped me with being able to come to the executive here with some ideas about how we could do some things differently, how we could work differently, and that's, I guess, why I was sort of invited to come across and look at strategy.
And what's a sort of maybe one? Thank you very much. I wouldn't have guessed you've been in health for 20 years, so that's absolutely super. We've not stressed you enough, actually. She's saying we have. I just wondered whether you could just reflect on some of the projects you're doing, maybe specifically the program around the Midland Hub that you're driving.
Yeah, so I guess one of the biggest issues that we faced in the community for a number of years, and we had many goes at trying to look at how we could provide better facilities for our community staff. I mean, we talk about the 150 or 60 sites that we've got out there, but until you've been around a lot of them, and I know you have, Aresh, and you see what they're like, some of them are really appalling and they're unsafe for our staff. And WorkSafe, I know I've been out to CAHS sites as well. So we've been really trying to provide safe, fit-for-purpose facilities for a long time for our community staff. And so to come across into the strategy role and have a focus on our first real investment in a larger facility for community health and for CAHS, it was absolute privilege and a real sort of culmination of a lot of work that was done by others as well as myself to have an opportunity to have really great facilities for the great work that's being done out there. And so the Midland Hub opportunity, I think, is such an exciting one because it is a sort of once-in-a-generation opportunity to see a building that can fit all the staff in the area and is fit for purpose. So it's got rooms that we can have groups and families in, and it's got the things that the clinicians need to deliver services. But it's also a fantastic opportunity for us to have a look at how we deliver services and how we interact with our consumers. Just the very fact that you're moving into a new space, and I'm sure our colleagues here in PCH could talk about this, it helps you to relook at the way you deliver services, to reimagine and be innovative about how we could work, how to celebrate what we're doing now, but also build and do some new things in terms of our services for families.
I mean, it's interesting, isn't it? Because I think one of the criticism we often face is that we don't celebrate the scale of transformation that CAHS is involved with in trying to improve the lives of children and families. And I think for two things. One is around the focus on the children and families, and secondly, the breadth of projects our staff are involved with. So, because the hub isn't a new thing, it's just that we're just getting round to getting somewhere where we're very clear about the real opportunity it affords. So, I mean, is it possible just to build on that theme of what you think it will be delivering or the vision that we've got for it?
Yeah, look, I think it's, as you said there, Aresh, it's about celebrating what we do really well, which is we provide fantastic services. You know, our child health services deliver services to families. 99% of newborns and families are seen by our child health services, so we have an awesome opportunity there. Then we've got great intervention services through our CDS, through our schools, through our mental health services, which are, you know, standing there really dealing with the most difficult and complex cases. So this is really about celebrating our existing staff, the evidence-based services they already provide, and providing them fit for purpose places to work from. It is also about thinking, what else can we do? We know that there's vulnerable kids in our community, and each one of the clinicians out there would know that there is some times when we know we are not getting to families. They either fail to turn up and we just don't have the time to get back to them, or they're touching our services at multiple points and they go on multiple waiting lists, or or they have a bad experience. And what we need to do, and many clinicians have already raised this with us as we're developing this project, is look at those places where there are gaps between our services, or where there's families that see us multiple times but have to wait, or they don't get the sort of supported and coordinated care that they need. So we talked to our families and they said seamless care and wrap around, putting the family at the centre is what they want. We talked to the staff and they said the same thing, and we talked to service providers. So I think there is an opportunity to build on the great services we're doing by addressing some of those gaps.
Can I just be keen on just challenging you about just one thing to educate me. We often talk about we've talked to families to help shape our services. In the case of the Midland Hub, what actually does that mean?
Yeah, we saw that one of the foundations for the Midland Hub was to really put in some effort to understanding what the Midland community wanted, because we can't assume that every community wants the same thing. So early this year, before COVID, we sent out a survey to 7,000 families that we had had contact with in the Midland area, and we asked them to fill in a survey about our services. We had 500 responses, so that was really pleasing, and the families told us a range of things about what they thought that we should do. We also went back to those families and said, you know, you told us about integrated services, you told us that you wanted to have wraparound seamless care. What did you mean by that? So we actually went back and asked them a little bit more, and we saw some families specifically there. So over 500 people have been consulted. We also asked the Youth Affairs Council of WA to speak to their contacts, and we did some specific sort of sampling of what young people think about our services. And we got a range of responses, as you could imagine, but there were those themes. So we didn't really do, we really feel that we did do a fairly intensive and purposeful, finding out what the community needs, and we hope that we'll continue that conversation with them as we sort of start to talk about what services we could provide in Midland into the future as well.
And I suppose one of the other bits is for us, it's interesting because we've talked so much in CAHS about partnership within, seamless care within. I just wondered whether we had looked at other providers in Midland to help enhance this, or is it a very CAHS-centric program that we're going to be driving?
No, because interestingly, one of the things that these consumers said to us, and it wasn't any surprise, is that they wanted to see a broader range of services delivered. They absolutely want our core services, they want our child health services and our CAM services, but they also wanted things that we don't deliver. They want family support services. They want us to have events that provide information about child issues that are in the community, and we can't deliver those, and I don't think we should. We're not funded to do that, but in partnership with our other providers we can. So we did actually go out to the community and speak to a range of service providers. Midland's got a number of service providers, and we actually worked alongside a non-government organisation called We the People, who worked together with WACOS, WA Council for Social Services, to go and speak to a wide range of child service providers and family service providers in Midland, and we asked them to tell us what they felt our role was in the Midland community and what the needs were there. And they gave us a report which made some really great recommendations about how they would like to keep working with us into the future, and their real commitment to work with us where we celebrate each other's roles but work together and collaborate. And they also talked about some of the things that the consumers talked about, which is sort of seamless care and having a really welcoming space, and those things, being culturally sensitive, things that were kept coming through in all the consultations that we did.
I mean, it's interesting. I know that, I've continuously am still learning about child health and what it really means. And one of the frequent quotes I hear is that it takes a village to raise a child. So the Midland Hub is more than just a building. It's a way of helping the community, helping children, and helping families.
Yep.
It's our role in that village. Is that fair?
Yes, I think it is, and I think it's a very purposeful. Sometimes you can have a co-location where people all are in one space and share a building, but you can have that just doing your job. We're wanting to take that a bit further, where we actually work with community partners where we make appropriate referrals, where we support families to get to and from different parts of different services that are offered. And it's not just a co-location, it's a real collaboration to wrap services around families.
And this also offers PCH an opportunity, does it? Or is it just a community services remodeling?
No, so we're going to have this great building. It's a theoretical building at this stage. We haven't quite laid a first brick yet. But we know we're going to have a building that is fit for purpose for the staff that we already have. But we want to have some, and we will have some flexible spaces, some extra rooms for particularly our colleagues here in PCH to come out and deliver services. A lot of areas in PCH already offer outreach clinics, not only in the metro area but around the state, and sometimes they have to sort of squeeze themselves into quite small small rooms. So we want to make sure that at Midland they have an opportunity to come and deliver full multidisciplinary clinics. There's some people that we've spoken to already, some subspecialty areas that are already very keen to get out to places like Midland and north and south, so that families don't need to drive long drives just to get to us to deliver services. So we are really looking forward to working together to bring some of those acute services out to the community. It isn't about delivering acute services out there, but it's about those services where we don't need to drag people into Nedlands.
Right across the city.
Yeah.
And I suppose just a big question, when?
Yes, this is a big question. We've committed to opening this building in the middle of 2022, so July 2022. That actually is not far away. It's only a couple of years, and it takes at least 18 months, 12 to 18 months to build the building. But I think even more than that, it takes us a while to work out through talking to clinicians what we'd like to do differently, how we'd like to work on those sort of areas where we know we're failing kids and that there's a gap in services. So we want to spend the next 18 months getting the design of the building right, talking to clinicians about how we get their core services supported, but also looking at those new ways of working where we know that there's opportunity to get to those vulnerable populations and support them and coordinate care a bit better and really talk to clinicians about how that can happen. And I just want to say I've been overwhelmed by the number of clinicians across CAHS who are enthusiastic about this. I think it makes sense to a lot of us who've been working with communities and working with children for a long time. So it's a really encouraging space to be in and an exciting project.
So we are tremendously privileged to have you. You're always very self-effacing about the role you play in driving this in the background. So it's great to actually have you behind the microphone, really celebrating this super exciting event. I wish you a very, very happy weekend, and hand over to DJ Houston.
Call now on 6456 5629 or 0436 595 600 to ask a question.
Beck, have we had any calls with any questions at all?
I have a few questions for you. The first one is, when is the main entrance at PCH reopening? And what about the northern entrance for staff? Is that remaining open as well?
So, look, this is a constant source of tension, because we are always sitting here hyper-vigilant, talking about the fact that we can't afford to be complacent. But at the moment, we are planning on opening the main entrance next week. I know that'll make a massive difference to people. So hopefully that'll see a dramatic change. I do want to just reiterate the fact that we are constantly looking, and I'm going to use a horrible management term, flow through the hospital, because I think we need to be in absolute control of it to make sure that if there's ever an outbreak, that we're able to really lock down quickly. So the main entrance in a week's time, and northern entrance similarly. Well, sorry, northern entrance will remain a staff entrance, yeah, sorry.
Next question is, have we heard anything about accreditation meant to be coming up next year?
Yeah, do you know what? We haven't. I mean, it's been accepted that accreditation will be delayed. We were due to have accreditation in November this year, or end of the year this year, but I think the main focus for us is accreditation is not an administrative process to get a tick box. It's an affirmation that we have got our systems and processes right, and that our health service is configured to keep our children safe, keep our families safe, and it provide a healthy environment for our staff to work in. So we are continuing the focus and drive on accreditation, irrespective of what an external accreditor may announce in terms of a date for a formal inspection. So at present, we have been discussing actually running an accreditation program in March 2021. That's not actually very long away. In reality, when you put Christmas in the mix and you put the threat of an outbreak in the mix, we have got a lot of work to do. So I actually really want to thank staff who've been driving this, but I want to remind us that accreditation is not an administrative process. Accreditation is affirmation that our systems and processes are safe and consistent in terms of the care and provision that we give. So now I think with that, it's time to bring today's show to an end. I want to reiterate my thanks to Dan and Sue for the lively input, Beck, Anna, Kate, the comms team, who do a huge amount behind the scenes, prodding, pushing, getting information together, and making this show possible. I want to reiterate my thanks to Radio Lollipop, without whom this wouldn't be possible. I'd like to thank all our staff for really the tremendous work that goes in each and every day, 24 hours a day, into keeping our children and families safe, and wish everyone a very happy weekend. And good luck to the supporters who follow the Eagles and those who follow the Dockers. I will remain neutral in this show, and maybe it will be edited one day for Saturday and one for Sunday. So have a great weekend, and thank you very much, DJ Houston.
Welcome to Radio CAHS, presented by CAHS Chief Executive Dr Aresh Anwar.
Welcome to Radio